Hi everyone. So today I'm going to be presenting my paper on modern financial incentives and child health, evidence from Pakistan. So the main question that this paper looks at is, can modest financial incentives for regular and more health care during and after pregnancy in the context of poor health indicators improve child health? Now, what is the motivation behind this? I like to call this the key figure or the motivational figure for this paper. So what this diagram summarizes is the change in stunting rate, which is essentially how children under age 5, their height for ADE scores have fared over a period of 2 decades in the whole world. So has there been an improvement, or has there basically been a decline in height for ADE scores or stunting? So the green color indicates that there has been a reduction in stunting, so that is essentially showing a negative growth rate in stunting. But an orange or a red color indicates an increase in stunting. So if you look at the map, you should be able to spot Pakistan there with only a few other conflict-affected countries. So Pakistan is one of the very few countries in the world that continues to struggle with increased stunting in the last 2 decades. So while this is an overall picture of the whole country, we can expect that there is going to be a lot of regional and provincial disparity, with some provinces doing far worse than the others, and then rural areas doing worse than the urban areas. So that essentially is what we find in rural Sindh. Sindh overall has been identified as a hotspot for stunting and malnutrition as measured by the prevalence of underweight children, and that is going to be much worse in some areas of Sindh, which are the more sort of poorer areas and the rural areas of Sindh, which is essentially the study area of this paper. So where the national average of stunting is 40.2%, in Sindh that goes up to around 45.5%. That's just highlighting the extent of the problem and how big the problem is. Now the question is, why should we care about these growth markers? Obviously there is the fairness argument. Every child, no matter what their socio-economic status is, should have the same opportunities and should have a healthy life. But as economists, we also care about numbers. So then why should we care about child's health? Because now there is plenty of evidence to show that what your early life health is, that is going to have a far-reaching impact on what your cognitive potential is, how well you do in school, and then obviously how well you do in the labor market, which is obviously going to matter for a country's GDP as well. So now, what was that modest financial incentive that I was looking at? This is a program that was rolled out by the government of Sindh in April 2022. And the motivation behind this modest financial incentive was that we need to give people enough so that they're able to cover their transport costs of getting to the hospital and back, or a day's wage that they're going to miss by making that trip. So the idea is that how effective is the transport subsidy which is targeted at pre- and postnatal checkups and for the woman to deliver at an institution, can that improve child health? So I answered this question by evaluating a government-run cash transfer program in one of the most vulnerable provinces of Pakistan with respect to health. And I employed a spatial discontinuity design because of the staggered rollout of this program. And the main result of this paper is that I find a significant impact in height for ADE score and obviously moderate stunting. So now where would I situate this paper? There are 3 areas of active research where I would situate my paper. The first is obviously there is a lot of work that is done on demand side interventions, trying to incentivize a higher take-up of maternal care, care during the child's early life. So this paper is actually looking at one such intervention, but this is a short-term cash payment. I wouldn't call this a conditional cash transfer because of the size of the transfer. This was a very small transfer, which is a transfer run, which is something that I'm going to talk about in a bit. So this is a short-term cash payment. Not much was invested from the government side in also making sure that the conditions are being met. There was no penalty on the woman or the family if a condition was actually skipped. So this is a little different from a conditional cash transfer, but this is an overall demand side intervention trying to get the woman to the hospital, trying to get her to avail services that can improve her health as well as her child's health. Then obviously child health in Pakistan, existing literature, we have, there are a few studies, they're looking at private interventions, small scale interventions. This is one study which looks at a government scale intervention which has already been scaled in the province of Sindh. We did this evaluation at its pilot stage in 2022. And then finally, because this was not a very big transfer, what is the cost effectiveness of a program like that, which is obviously the increasing focus of social protection now going forward, because social protection has become such a popular tool and such an important tool to address poverty and related issues that increasingly people are now discussing what is the cost effectiveness, are there other effective ways of doing it. So this paper also sort of contributes to that literature, because this is looking at a modest reimbursement in the context of compliance and payment gaps. So very quickly, what this program entailed, it covered the first 1,000 days of life, that is a woman's pregnancy, as well as postnatal checkups during the first 2 years of a child's life. So there were different checkpoints. We had 4 antenatal checkups, institutional delivery, and 10 postnatal checkups. The transfer amount, the total cash transfer amount for all these various checkpoints was around 30,000 Pakistani rupees, which is just a little over $100 US. So if you were to kind of calculate a per visit or condition average, we're really looking at $7 US with a monthly payment of actually $3 US, and that's not even like 10% of the monthly expenditure on foods, like a really modest sort of reimbursement that is being done by the government. The eligibility was just based on the woman being pregnant at the time of registration. She has to be at least 18 years of age so that she has her CNIC, against which also the residents of her district can be verified. And this was done through a self-registration mechanism at the government hospitals in the area. So now a bit about the program implementation and the staggered rollout. So this was rolled out in 2 phases, and we coordinated with the implementing partners to accommodate the evaluation timeline. In the first phase, this program was introduced in the orange districts, which are there in the southeast, namely Thalbarkar and Umarpur. This was done in April 2022. And then in the second phase, October 2023 onwards, which is roughly a year and a half after the first stage, the program was then scaled to the remaining 3 districts, and this is where the program has been operational since. So because of the staggered rollout, I was able to use the spatial discontinuity design by getting my treatment sample from a district in the phase 1. And then getting my control sample from the neighboring district, which got the program in October 2023 in phase 2. So how did we collect data? This was a very ambitious and interesting activity, getting data for this evaluation, and it was basically, the inspiration for this was coming from the work of Cake and Abu Bakr. Their work was published in the Journal of Development Economics in 2019. They did a similar evaluation for a much bigger CCP targeted at pregnant women in Nigeria, and the idea was that first they did a listing, and that's what we did. They did a listing and census of pregnant women in the area, and once they had that entire population population essentially, they then drew their sample from it for the final evaluation. So the way that we did, just a bit on how we did the listing and census of pregnant women, we used services of the local resource person. This could have been the local lady health worker or community worker, or anyone in the area who would have information about pregnant women and where they reside. And once we identified where they reside, we would actually go and do a 5-minute survey and then do a snowball approach by asking them if they know pregnant women in their household or in their neighborhood. So once we had that population, we used a sample of around 4,000 women. So now, like I said, this was a spatial discontinuity design. We knew that the program is going to go in Umarkot in the first phase, and then it's going to go in the neighboring district of Mirpur Pass in phase 2, and that is where it was introduced right after we had our first follow-up on our grid survey. So the border or the boundary between the two districts, it actually became our treatment assignment. And the identification assumption here was that observations in very close proximity, but on either side of the district border, are going to be similar enough for a valid comparison. So we basically did quite a bit of work to determine what is close enough. We had access to some very detailed household census data that we used to identify what area of the two districts are going to be comparable enough. So we used that household census data, used the poverty indicators from that data to get a bandwidth of around 10 to 12 kilometers. So obviously we had two constraints and there was like a trade-off. One was that we had to get enough observations so that our study was powered enough. So we had to sort of, expand the bandwidth. But on the other hand, we couldn't go too far because then we would lose the proximity. So, we were trying to get that sweet spot, which we feel was the 10 to 12 kilometer bandwidth. So this is essentially the map of the control treatment. The control is to the right and the treatment is to the right and the control is to the left. These dots represent the geolocation data of the women that we interviewed in the sample. This is about 4,013 observations that we got in the baseline. And the brown line is essentially the district border. We can get to this later. We basically ran into some, sort of unexpected baseline imbalance issues, which we tried correcting, but we can take that into discussion bit. So this is what the main specification looked like. We used the specification used by Dell and Dell et al. And essentially the idea is that we had two measures of location. One is how far you are from the border, and the other is what part of the border are you closest to. So we controlled for that, and then we added a bunch of control variables essentially, because this is not a randomized design. The important thing was that our results should be stable with and without the control vector. So just with the location controls, we should be getting balance, and then our main result should be stable with the inclusion and the exclusion of the control variables. So our main outcomes were higher than A grade for AC scores and the prevalence of moderate stunting and underweight for the children in household I born in district E close to water segment B. So the main coefficient of interest is beta 1, which measures the intent to treat effect, because we're looking at the effect of treatment eligibility here, whether you are in district, whether you are in the treated district or whether you are in the control district. The GXY is the location polynomial, which is essentially capturing the distance from the border. The delta B's are the 20 equidistant boundary fixed effects. We control for all, sort of usual household controls, parent and child controls, health facility controls in the area, enumerator fixed effects, because we had anthropometric measurements, and then we also control for older sibling controls, which is essentially an important robustness check. This essentially is the measurement or the anthropometric measure of the child that was not the target child of this particular cash transfer program, but was the older sibling of the child targeted by this cash transfer. The standard errors are clustered at the revenue village level. These are just some sort of falsification tests to sort of establish balance using our preferred specification of just controlling for location. And then our results show that there was an improvement of 0.3 standard deviation in height or age disease score, and there was a reduction of 8 percentage points in moderate stunting. The evidence for weight per AZ scores and therefore the prevalence of underweight is essentially weak. The results strengthen in the narrower bandwidth of 5 kilometers, so I don't want to read too much into it because I haven't really sort of established are they statistically different or not. So just contextualizing our effect size, this is sort of in the ballpark of what other studies have found in similarly disadvantaged areas. And there is this idea that we can expect a much higher gain in the context of larger growth deficits, which is the case for places like sin. So we also did some back of the envelope calculation to get a benefit to cost ratio of 2:1, and this is like really a lower bound because I only used the costs, the sort of costs that we are being able to avoid by going to school regularly if they're able to reduce study. So this is really not capturing any sort of long-term costs of your labor market or GDP. This is like a lower bound of the cost to benefit to cost ratio of 2:1. So very quickly, did it sort of make a difference on the margins that the cash or the modest financial incentive was introduced to make a difference on? Women in the treatment area were 3 percentage points more likely to go to antenatal checkups. The most sort of profound impact was found on postnatal checkups for 12 percentage points. And then the ratio of postnatal checkup visits also improved by 4 percentage points, which is essentially saying that there was at least one more postnatal visit. I do not find very strong evidence on other sort of mechanisms such as dietary diversity and food sort of your FIS, which is your food insecurity scale. But the way that I am looking at the mechanisms is what is really happening at the postnatal care. So this is just an excerpt from the documentation of the government and what they're supposed to be doing at the postnatal checkups. And you can see that the healthcare provider is supposed to get the vitals, is supposed to give the woman iron folic acid supplementation, and they're also supposed to counsel people at breastfeeding techniques, sort of complementary feeding and techniques just like at 9 months. So the idea that this is sort of presenting is that while cash transfer amount was modest to not bring about a very impressive change in what was actually being consumed in the household or improve food dietary diversity, but there was something happening at these postnatal checkups and increased information that possibly was leading to the effect that we observed. This is something that we can sort of discuss more, and I can take more feedback on that. And then we also found that in the treatment district, the health facilities also saw an improvement in their obstetric and newborn care services and child nutrition services. So this, I like to call it the founding channel, because the idea is that it is possible that the supply side responded to a demand side intervention coming from the area, and there were sort of improvements made on the dimensions that really mattered for child. Yeah.
So I have a few questions and comments. It's mainly related to the methodology. The first one is treatment performance. As we discussed, in the deadline, there were pamphlet distribution, so there were information treatment. So if there were treatment, information treatment in the deadline, how could we differentiate the impact, whether it is from the information side or from the transportation side? So it's really differentiate. In addition, you also documented there were facility quality improvement in the treatment district. So if those improvements were correlated with or triggered by the program, it's also difficult to differentiate whether the improvement in the malnutrition are from the facility improvement or from the transportation side. As well, the timeline in the span period is highly related to the period of inflation. So but you didn't control for these aspects in your regression. So if you try controlling this information like inflation, local price type of controls may help. As well, the incentive was given for all the pregnant women, irrespective of their income. So if you run quantile-based penetration strategy, you can tell which part of the population is more benefit from the program. In addition, as a comment, usually our theoretical justifies there is no manipulation around the theoretically, but it's good to back that theoretical education by empirical analysis by running the density tests. So running this, you must plot this to make to see whether there is manipulation in the talk or not. Finally, falsification test use all the siblings to see whether to run like falsification test, but all the siblings, the program or ways that you make might affect all siblings through resource relevance. So maybe considering like baseline mother's characteristics and run falsification test may help more. So these are my comments.
Thank you. Thank you for including the paper in the program, and I know August 14 will be our National Day, so for those from Pakistan, happy National Day. I really feel your joy and happy to be here at this time. And I guess I can directly jump in. So the paper, the motivation is very straightforward. Every year, more than 3 million children, infants, and over 600,000 pregnant women die in childbirth. And many more suffer from severe conditions that affect the rest of their life. And then WHO has been, and even healthy women, like every childbirth has a risk. So then to address this critical issue, the WHO has been promoting skilled birth attendants, acronym SBA, which refer to the presence of trained midwife or doctor at childbirth to perform hygienic delivery as well as first-line emergency care. And then here you see the picture, even after decades of promotion, there are still many countries, especially those in South Asia and Africa. You see Pakistan, Afghanistan were the two, still have low SBA rate. And then even for a country like Peru, with like an overall 94% SBA rate, there are still many provinces with like an SBA rate as low as 50%. So we still have a long way to go. And then so far, studies on this on SBA, the effect has clearly proved that it's effective in reducing maternal and neonatal mortality rate. Yet there's few studies look at the long-term benefit of SBA, especially in developing countries, partially due to data limitation. And then on top of that, literature predicts that the SBA benefits should echo across generations, yet there hasn't been any empirical studies to confirm that. So then, with this motivation, we try to fill this gap in the literature to take advantage of the rollout of SBA in China from the 1930s to 70s to identify the long-term and multi-generational benefits of SBA. And in particular, we use the standard GID model to show that children exposed to SBA at birth have about 1.5% higher income in adulthood. And on top of that, for the second generation, children with at least one parent exposed to SBA at birth, they report about 2.6% higher income in adulthood compared to children with neither parent experienced SBA at birth. And then this effect, on top of that, the effect is more pronounced if the mother instead of the father was exposed. And then we think that, and then besides the income effect, we further identify several underlying mechanisms, such as health channel as well as education channel. And then we think this paper has very important policy contribution because there's still hot policy debates about the benefit of SBA in developing countries. Well, as I mentioned, WHO has been promoting for decades. There's still most of the evidence of SBA benefit are based on developed countries such as US or UK, instead of very few studies based on developing countries, as I mentioned, partially due to data limitation. And then, moreover, there has been little evidence to look at the long-term and cross-generational benefit to have a comprehensive, cost-benefit analysis. And then, so here we use a rich set of administrative NIF and the household survey data to show that the SBA can have a very substantial long-term and multi-generational benefits. And so, as such, our results provide credible evidence to this important policy issue. And then, and then I hear a little bit more background information to show you that the SBA practice was first introduced to China by missionary doctors from Western countries in early 20th century, such as missionary doctors from UK or US. And then they not only themselves practice hygienic delivery to local children, but also they are very generous to teach local doctors this SBA practice. And then after World War II, when China finally settled down and had the time to focus on the domestic development, they observed that significantly lower maternal and neonatal mortality rates in those missionary cities. So they decided to roll out this policy nationwide. And then by the end of the 1980s, almost the whole nation is covered by this health initiative. And then the local government offered this SBA service free of charge. So that's why the compliance rate has to be very high. So pretty much 5 or 6 years after a county introduced this health initiative, more than 90% of the live births are attended by a professional, trained midwife or doctor. And then, as I mentioned, we use the standard DID model where we dig into the historical record to identify the exact year each county introduced this practice. So specifically, we have 1,721 counties with exact year to start. And then, so here, I show you the spatial variation. You can see that even neighboring, first the darker the color, the later the county starts the practice. So you can see even neighboring county has very different color. That gives us very substantial variation for identification strategy. And then here you see across years, there is very small set of missionary cities practice this SBA services before 1940s, and from 1940s to 1970s, we have a nationwide rollout, and then by the end of the 1980s, the whole nation is covered. And then in case you worry about selection bias, we show that clearly there's a small set of counties that didn't keep the record, but we show that the counties with record of exactly which year they introduced the practice, they share very similar features as the non-reporting counties. So there's more details, more detailed information in the paper to address selection bias. So if you have questions, you can ask me later. And then, as I mentioned, because the participation, the services are offered for free, and so the participation rate was very high. So we have two control groups. So within the same county, we compare the treated children with the early non-treated cohorts, as well as their offspring. And then across counties, we can compare the early versus later treated counties. And then definitely migration is a big concern when you do the historical record, studies. Unfortunately, for my research, I guess not so fortunate for the local people, but the domestic migration was highly restricted, up to early 2000. So during our study period, so due to the strict domestic migration policy, so a child's birth day and birth county can nicely proxy the treatment status. And then in terms of data, the first generation, we use the 1935 to 65 cohorts who were directly exposed to the SBA rollout. And then the second generation, we look at the children of the first generation. So specifically, we look at the cohorts 1976 to 86, who are at least 20 years old when we collected the income outcome, the data, and also not overlap with the first generation. And then we also want to mention, because once the county starts the practice, the SBA practice, the policy stays in place. So the second generation, almost 99.9% of children already covered. So that's why here it's conditional on the second generation all covered. We compare if there's a spillover effect from the first generation. And then our main outcome variable is the monthly personal monthly income, which is reported in the 2005 population census. So if you ever want to use like that's we are very grateful because usually census don't collect like a detailed income data. So this is the only census that give us like more than 100 million observations with income data. And then on top of that, the census also collects quite a few like educational outcome variables. For instance, like years of schooling and whether you graduated from primary school all the way to college. And then here you see like this is like to show you there's quite spatial variation in terms of like the portion of children in different cohorts where the exposed to the program. And then on top of the census data, we also use the household survey data, which give us quite some like physical education, physical health measure, as well as mental health measure. And also we use the second household survey, CFPS, which give us measures of cognitive outcomes, such as like the math and verbal test score. And then here are the summary statistics. You can see about like I want to point to panel B that show you about like the panel B and column 2. You see about 52.5% of the children in our sample are exposed to SBA at birth. And we have a very standard DID model where our key dependent variable is SBA, which measure whether a child or their offspring or their parents were exposed to SBA at birth. And then here we first show the short-term impact on neonatal mortality rates. So sorry, I didn't include the baseline mean. So before the SB practice was introduced in the county, on average there were like about 20 to 30% mortality rate. So you see the coefficient of SBA was about 21. So which means that it's about like a 50% reduction in neonatal mortality rate from about 20% to about 10%. And then the results are very robust across different specifications. And then here is the event study graph to show you, like on the x-axis, it's the negative value represents children born before their county started practice, and 0, and the positive value represents children born on the year when their county started practice or born after. So you can see that for the negative value, we don't have pre-trend. It's very around 0. And then once the county started practice, there's a persistent and significant decrease in neonatal mortality rate. And then, so in case you are worried about the quality of the historical data, the panel B here to show you that the cohort size from the 2005 census, which exactly in line with the historical neonatal mortality rate. When the neonatal mortality rate decrease, the cohort size correspondingly increase and stay high. And then in terms of like the income variable, we show that in the first generation, children exposed to the SB practice has about 1.5% higher self-reported monthly income in adulthood. And then again, here's the event study curve to confirm we are not suffering from pre-trend, and there's a persistent increase in income for treated cohorts. And then we do further decomposition to show you that the increase in monthly income, a big portion of that is from the increase in hourly wage. So to show you that show you the increase in income, it's largely come from the increase in productivity, marginal productivity instead of a trade-off between work and leisure time. And then after 2020, right? We have the team for the Callaway and Santana, so we show you our results survive those robustness checks. And then this is I will quickly go through. So for the first generation, the treated cohort reports much better self-reported health status and have a lower chance need to visit a doctor due to physical discomfort, and they on average have a lower chance to report negative emotional states. And then also the treated cohorts on average have about 0.07 more years of schooling and have a higher chance to graduate from primary school all the way to college. And then they also on average do better in the test score. And then again here to show you we survived the event study, pre-trend and consistent effect for treated cohorts. And then for the second generation, as I mentioned, the children with Here, the control variable are the children with neither parent treated by SBA, and the treated group are with at least one parent. So you can see children with at least one parent exposed to SBA and birth had a report about 2.5% higher monthly income. And again, we survived the inner study curve, and then this is the table I'm most excited about to show you when the mother was exposed, children get more benefit, and then for the offspring side, when you are a female offspring, you get more benefits. So overall is that if your mother or both parents were treated and you are a female offspring, you get the most benefits. So we show that this practice also reduces gender inequality. And then I will just quickly to show you also a big part of this monthly income increase comes from the increasing hourly wage, and then survive the robustness check, and they also report better health status as well as higher educational outcome. And then again, we survive the study curve, and the last but not the least, we show this program is highly cost beneficial. So even just the increasing income in 2 years in adulthood is more than enough to cover the cost of SBA practice and birth. Yeah, thank you.
So this was a very interesting paper, and it's hard to really find common sense and everything. It has been through a round of several rounds of feedback, and it sort of showed that reason activities. There's just a few sort of suggestions, and I'm wondering, you sort of talked about how those early and late treated counties, even some of them or most of them, were like neighboring. So do you expect spillovers? Do you sort of see the results change when you restrict to those, whereas you sort of exclude those from your analyses? And I'm just wondering, I don't know if you would do that or not, but maybe something along the lines of household mixed effects for the first generation, like to get a sample of sort of people within the same household who were exposed and not exposed because of how the timing was of the SBA rollout. And then I didn't get a chance to sort of really go into detail of the mechanisms, but there was quite a bit of discussion about it in the paper. Sort of showed that there was an improvement in self-reported physical health and mental health, and sort of the outcomes related to education as well. But I'm just wondering if there is some actual morbidity data to support sort of or supplement the self-reported physical health, which showed improvement, and then something sort of more sort of in line morbidity, so like the disease burden, just because of the SBA rollout, you have safer deliveries, and then relatedly, because we're expecting the women to be in safer hands, do we see also something, there is an improvement in sanitation, vaccination, something along the lines which are more immediate mechanisms, and that can explain better health, and then obviously, from that point onwards, sort of channel to make the benefits. And that could be the case, but I'm also thinking if, I think for confounding factors, if you have data on something like sanitation or vaccination, maybe you can do the event study or something that as well. And then, because, two things could happen. One is that was the program sort of going to places where it was needed the most, and maybe that data could, that event study could also sort of shed more light on it. But also, sort of, we have a safer delivery, the woman is exposed to someone who has more information and can share that, and then we see that being translated into improved vaccination, better care, etc. And then just wondering if that also sort of had an impact on hospital infrastructure, because there were further cases. I think there was some sort of discussion about it in the paper, so maybe that. And then just relatedly, if you could do a bit on heterogeneity, and maybe this program were better in high disease burden areas or sort of more poor areas, just to what it was like. And yeah, I think sort of that was what I Thank you.
Okay, thank you so much. My name is Mr. Rami. I'm from South University. The dynamic impact of early childhood on education and time allocation is the title of the paper I'm going to present. It's a joint work with Professor Nasser from University of Rotterdam. So, in this paper, we try to answer two important research questions. The first one is what is the impact of early childhood on mother's education and time allocation? And the second one is, do the impact varies by mother planning, age of exposure, and length of exposure? The motivation behind this study is that early childhood is a pervasive global problem, and it has significant social, economic, and health consequences, particularly for young women and their families. So there have been so many global efforts to reduce adolescent pregnancy rates. However, early childhood remains prevalent, particularly in low and middle income countries, and poverty, limited educational opportunity, as well inadequate access to healthcare contributes to 8%. And the effect of early childhood is not limited to the individual. However, it has a broader societal outcome. It creates intergenerational poverty, as well it negatively affects overall economic development. And globally, about 12 million girls aged between 15 and 19 give birth each year. So this figure shows how prevalent early childhood is. So what we do in this paper, we identify the impact of early childhood on educational attainment. So we use years of education and enrollment, probability of enrollment as in an paper. As well, we estimate the impact on time allocation decisions, and we consider time allocation into broad categories as unpaid and paid, and unpaid activities include risk, care, core, and task. So what we contribute to esteemed literatures, first we add on development economics literatures, which mainly focus on societal norm-driven practice on the well-being of young girls and women. And you may find so many papers related to the impact of early childhood on educational outcome or on education, and also a few papers on the impact on time allocation decision. So the main issue in estimating the impact of early childhood is the obese problem, endogeneity problem, because women's experience teen births may differ from those late childbearing. So to overcome this, different researchers use different methodologies, like for instance, some of them use instrumental variable approach. Some of the literatures use instrumental variable approach, and they mainly use miscarriage as an instrument. Others use within family estimator, and relatively all literatures use ONS and testing. However, there is inconsistency in findings. That might be mainly due to difference in statistical approach, variation in population studied, as well as some of due to methodological limitation. For instance, in instrumental variable case, a miscarriage may not fully satisfy exclusion or restriction, and for case there is a strong assumption behind. So to address this challenge, we used the most robust impact evaluation method, which is DID, and we applied staggered DID, which also has an advantage to help us to estimate the dynamic effect. by exposure period and timing of malnutrition. So data source, we used panel data source, that data from Young Life Survey. Young Life Survey is like a longitudinal survey which follows over 12,000 children for over 15 years from for developing countries, Ethiopia, India, Peru, and Vietnam. So our focus is only Peru. And Young Life Survey follows two cohorts, children, young and old cohort children. And we only focus on cohort from Peru. So descriptive statistics is our descriptive statistics of the outcome variables. And next, covariate balance. So as you see, treatment and control groups are pretty much similar, except with base. In clinical strategy, we used staggered ADE by Callaway and Santana. And but in using this staggered ADE, there is one concern, which is treatment techniques. So in our case, a treatment technique may occur when mothers experience child death. Despite the ongoing trauma and psychological pain associated with childbirth, loss of child may trigger mother's situational affiliation and time allocation decision. But luckily, this event is very rare in our case. Only 3 observations experienced child death. So in robustness analysis, we even consider these 3 observations by excluding all these 3 observations and as well by including child death as a covariate. So this is a model specification we used to estimate the overall effect of early childbearing on education and time allocation decision. And we used children who never had child as a counterfactual, but in robustness check we also use not yet mothers as a counterfactual. So staggered ADE allow us to estimate heterogeneity analysis and dynamic impact. So for that we used this specification. So let me directly pass to the main results. So as you see, early childbearing reduces mothers' years of education by about 70%, and it also decreases probability of completing primary education by 6% and probability of enrollment by 33%. Then we estimate heterogeneous effect by mother timing and age of exposure. So by mother timing, we have 2 cohort treatments. Those who have child between age 12 to 15 and 15 to 18. So the impact is high, relatively high for those who have child early. By age of exposure, we have 3 categories or 3 groups. Impact at age 15, age 19, and age 22, and the impact is relatively higher at age 22 for years of education. Similarly, for probability of enrollment, the impact is high for those who are child early, and the impact is relatively high at age 19. So next we estimate the impact of early childbearing by mother timing by length of exposure. So by mother timing we have 2 groups who are child between 12 and 15 and 18. So for those who are child between 12 to 15, The immediate effect of early childbearing is statistically insignificant, but as the length of exposure increases, the impact becomes significant. For those who are child between 15 and 18, both immediate and long-term exposure effects are statistically significant. For use of education, for enrollment, the same is true. For those who are child between 12 and 15, the immediate effect is statistically significant, but as the length of exposure increases, the impact becomes significant, and the magnitude decreases. Then impact by length of exposure for the whole sample. So both immediate and long-term impacts are statistically significant, but as the length of exposure increases, the impact becomes higher and higher. The impact of early childbearing on time allocation decision. So for unpaid activity, the impact is positive, and those who are child before age 90 allocated almost more 27 hours per day more than those who never had a child. But for paid activity, the impact is negative and statistically significant, which is 9% reduction in time allocation on paid activity. But the impact on paid activity mainly comes from care and work activity, which covers about 24% impact. Then, similarly, we run heterogeneous effect by mother timing and age of exposure. So the impact is high for those who are child early for unpaid activities, as well the impact is relatively high at age 50 for unpaid work. For paid work, the impact is statistically insignificant for those who are child between 12 and 15. This might be related to age limit to participate in work activities, but the impact on those for 15 to 18 is 9% reduction. Similarly, at age 15, the impact is statistically significant, but at age 19 and 22, the impact is negative and statistically significant, and the impact is more prevalent at age 22. We also estimate the impact by mother timing and length of exposure. So for unpaid activity, those who are child between 12 and 15, both immediate and long-term impacts are statistically significant. For those children who are child between 15 and 18, the immediate effect is statistically significant, but as the length of exposure increases, the impact becomes statistically significant. Then dynamic effect by length of exposure. So the impact both immediate and long-term impacts are statistically significant, and as the length of exposure increases, the impact becomes more severe and severe. Then we run different robustness checks to see the consistency of the results. First, we consider treatment techniques, and we exclude those experienced child base, and we run the same preparation, and the results are similar. Also, we include child base as a covariate, and the results are consistent. Next, we used located qubit as a control, or as a control factor, and the results are similar. And finally, we used alternative methodology proposed by Woodbridge, and the results are similar. So conclusion, early childbearing has significant negative effect on education and time spent on work, paid work activities, but it has positive effect on time allocated on unpaid activities. So the impact is 70% reduction in years of education, 6% reduction in probability of completing primary education, and it also reduces probability of school enrollment by 3%. It increases time allocated to unpaid activity by 27%, as well it reduces time allocated to paid activities by 9%. So, thank you.
Yeah, I'm the discussion, and so I want to. Yeah, I think like this paper is examining a very important question, especially for developing countries, which is about how like a teen childbearing, right? And then then they use data from the young life panel study in Peru, which spans like 20 years, right? So and then. So like they use I think all three people are using similar identification strategies like ADE, and then they show that in this identification strategy, they show early childbearing can lead to quite some deleterious outcome, right? You have 6% lower chance of completing your primary education, and 17% are not going to read out this. Purely because last slide was the same thing. So I want to first give a big credit to the paper. It's still a preliminary draft I received, so I will be so excited if you have a follow-up draft for then I will also be happy to read and provide further feedback. But I think it is very important research question, and especially to global south countries, and also they have a quality and rich data sets, empirical data to look at this question, and they have this rigorous identification strategy as ADE, and then they have solid results. And then that's my complementary. Now let's go to critics, right? So first, we already talked briefly. He mentioned, also in the presentation, it's based on 4 countries. I think that will be the first thing. If you send the paper to any journal, they will be why you only use 1 country, and from our preliminary topics, because the other 3 countries still have kind of selection, suffer from the pre-trend. I understand. Well, I really encourage you to maybe check out, for instance, in my paper, we also, as I mentioned, we have to add the province fixed effect. If there's additional control variable, and for us, it's think that across different provinces, there's definitely, this early versus treated, but within the same province. It seems to be more or less very random. So I'm encouraging you to look at if there's additional condition you can add to get rid of the pre-trend, because that's very common, right? Sometimes, because so far you're only controlling for household fixed effect and personal fixed effect. That's very preliminary, right? Usually we add additional, usually a regional or or even by different education levels. I think there are many ways you can still explore to take care of the pre-trend, because I think you should be confident. That's sometimes I do. If I get a small set of data, I find the results are very robust for pre-trend. If I get more data, it starts to show pre-trend, I will be much more confident to see it's much there's just additional variable I haven't maybe taken care, instead of once you have a small set preliminary results, so you should be confident to just dive deeper into robust check. And then also on the paper, I think this that's my main feedback, and then all the rest are more kind of technical. So you mentioned this paper examined the social norm-driven practices. I think that kind of a little bit in the way saying. So you can actually see the causal effect of teen childbearing. That itself is a very important question. You don't have to further generalize to a more general topic. Itself is already important. And then in terms of this is I'm not so, you mentioned, but I still not so sure, because you mentioned you use children without child, which I understand. But don't you see, in the robust check, you use children who have not yet had a child. To me, I thought that means that children without child. So anyway, I think you may want to explain further what's the difference of the 2 terms. And then also, I think also this is, one critic major one was the pre-trend, you mentioned why you use only Peru, but secondly that you actually mentioned in the paper there's no short run impact, which I think a little bit suspicious, because actually I was thinking if you have a child, the largest time investment that is demanded is the short run, right? When the child was young. So that's why I'm a bit concerned why you didn't find short-term impact, in terms of affect their enrollment in school or they look like the short-term effect, but they find long-term, which I think is not in line with the time demanded or like the cost of teen child bearing, short run versus long run. So I think you may want to justify why that's the case, no short-term effect. And then always just like, I think if you want to, when you send to a journal, make sure you check all that, which happens, also to me sometimes I just copy paste the footnote and the footnote in the details. Because clearly here you are using education, but in your footnote or like the notes, it's referring to like time spent, activities. And then another minor comment is that if you look at here, right, this graph versus this graph, you are using different times of treatment, right? You have like a pre-period. You have here -1, -2, but then you have here -1 all the way to -3. So I think that's not so common. To me, I don't think if as a reviewer, maybe you need to think, maybe you start to have some pre-training the first graph, so you cut off the -3 period. So just make sure, I think usually you should have the same period in your study. I think that's that's the last one. Thank you.
Okay, thank you so much. I guess most of them are comments, so I'll take all the comments. But let me start with the last figure. Normally, in most cases, there are two different years, but the difference comes from the methodological aspect. So in the first plot, I use color and standard, and for the last one, I use Woodbridge. So when you run the Woodbridge analysis, it gives you such kind of plot, and but there is no additional time or prepared time in most cases. In most cases, there are only two different years. So the next effect, I'll try that. But I also have another paper, the impact of this yearly marriage on different outcomes, and we use all 4 countries and get the same pretty much the same result for 4 years, 4 countries. But for early children, only the front trend only works for 8. And for India, Ethiopia, and Vietnam, it doesn't work. So India and our trend assumption is MS8 to satisfy. So that's what we don't want to see. But as you comment, we also try to see biological effects. So I guess without child and not in child, one point. The difference.
Children without child versus not yet children not yet.
Without child means those children who never had child across all waves. But at the end of the child wave is staggered. So, for instance, in 4th wave, some of the children may have child, but in 5th wave, some additional children may also included in the treatment. So, those between 4 wave and 4 wave 5, treatment interest between 4 wave and 4 wave 5 after the transloading 4 wave 4. So that's why we noted noted mothers. Short-term impact of insignificant impact on enrollment. I don't have an explanation for that, but yeah. So, no short-term. Mainly, no short-term effect comes for time on paid activities. That's probably due to age restriction to enter to the labor market. In most countries, the minimum age is 18. So at age 15, it might not be logical. The impact is significant. So that might be the reason.
You may want to add that, right? We have results and then you can explain why there's